So I think since our last call, I think people are feeling a little bit more like they understand a little bit more about what's happening with current legislative efforts specific to Medicaid, and hopefully you'll feel better at the end of the call today. And then we have a second question. Have you been advocating on behalf of Medicaid with your elected officials? If you can just give us a little bit of an idea. Can folks see those results? It looks like many of you have been reaching out to members of Congress, which is wonderful. So I think we could take the poll question down now. And I just want to, before I turn it over to Gail, who's with us from the House Energy and Commerce Committee, I just wanted to share a little context to remind us about where we are specifically with efforts on the Hill and what's going on at present. So let me ask Kim, Kim's able to bring up my slides, which is great. So let me just start by saying that we are continuing to monitor what's happening in both the House and the Senate, right? We've got Kim, can you go to the next slide? We've got this timeline, right, that we had from Speaker Johnson at the beginning of the process. This should look familiar to you. So we have a House budget resolution and we have a Senate budget resolution. And so what they really have to do now is figure out together how they're going to move forward. And so because the House and Senate have taken such different approaches, this complicates the picture a little bit, right, in terms of how things will move forward. The House budget resolution, next slide, is a one big, beautiful bill, right, in President Trump's words, right? It's a consolidated approach. It calls for $4.5 trillion in cuts that are being sought overall. $880 billion specifically targeted to health-related cuts and specifically Medicaid. The Senate has taken a different approach, right? They're looking at a two-phase approach to budget reconciliation, an initial framework to fund border security, military funding, and energy, with plans for a tax bill later in the year. So the question that's looming, right, is now the Senate and House have to pass the same budget resolution, and how are they going to move that forward? And so Gail is going to talk with us a little bit about what's happening with the House Energy and Commerce Committee. Of course, that committee has jurisdiction over identifying cuts to Medicaid. And at the same time, Senate leadership has to decide what they're going to do. Are they going to move toward the House approach, or are they going to stay on their own approach? And how does that get reconciled with the Senate Help Committee having jurisdiction over identifying cuts to Medicaid, the Senate Health, Education, Labor, and Pensions Committee? So next slide. And just a reminder, there's lots of ways that Medicaid can be cut, right? And so the majority plans in Congress thus far have talked about open-ended entitlement financing to per capita funding, so per capita caps. They've also talked about eliminating the enhanced federal payments as part of Medicaid expansion, work requirements, and provider taxes. And so a little bit later in our forum, Leo is going to share more details about what some of these cuts could look like and how we're working to overcome some of those opposition or challenges to refute those cuts. Leo is with the Georgetown McCourt School of Policy, and he is, we asked him to come and give us a better situational analysis, right, of some of these ways Medicaid could be cut, including more recent conversations about provider taxes. So Leo, please, we're so
Thanks so much, Sue. I want to thank the Lutheran Services team for organizing this great event and for inviting me. So happy to see all of you engaged. This is such an important time. We were so lucky to hear from Gail, who's over on the Hill working tirelessly and effectively on behalf of Medicaid enrollees. Some of the issues, like work requirements, just seem to get a lot of attention, but we have some big and growing risks that do not get enough attention. So I'm going to talk about two of those. The first one is provider taxes, which are poorly understood but are a big concern. And the second one I'm going to talk about is risks to Medicaid expansion, in particular, how the Medicaid expansion population is not well understood. And then we're going to take a little time to try and separate some fact from fiction. So hopefully you can see my slides. And so we're going to dive into our first topic, which is Medicaid provider taxes. Um, as you all know, Medicaid is jointly financed by states and the federal government, and states do get generous federal matching funds for every state dollar they spend, but states struggle to pay their state share of the Medicaid costs. One way they, in fact, raise a lot of money for that state share is through provider taxes. The state levies a tax on providers and then uses that money to fund the state's share of the Medicaid costs. And these provider taxes are critical to how states finance their share of the Medicaid costs. 17% of the share nationally is raised by provider taxes, right? So that's nearly 1/5 of the program being funded this way. And it's very, very common. Every state except Alaska is doing this. 39 states have at least three of these types of taxes in place. What's really important for you to understand is that this provider tax, it's like a lifeboat for the state. That's how I want you to think of it. When they have a local recession, right? And what happens in the state? Tax revenue drops. And suddenly they can't meet their budget. They have a budget shortfall. And instead of going in and cutting Medicaid or cutting education, which is the biggest share of state dollars, they can implement a provider tax. They can raise cash, fill up that budget hole, right? And weather the storm. Remember, all of your states, all the states out there, they have some kind of balanced budget requirement, right? They cannot deficit spend like the federal government does. They have to plug up that hole, and this is the critical tool. And it's also really helpful if the state suddenly has an idea or an opportunity to fund something new in Medicaid, right? Like when Medicaid expansion came along. If reddish or even bluish state legislatures had to pay all the bill, they might not have done Medicaid expansion or they might not continue to do it. So the provider tax is like a politically viable tool to generate the state dollars to do it. So how does this tax work? Let's start with who gets taxed. The tax can be levied on any specific group or class of providers, or multiple ones, that the state chooses. The statute actually divides like providers into 19 different classes that you can target any of these different classes. The biggest targets of these taxes are definitely hospitals and nursing facilities, right? More than 45 states are targeting each of those groups. ICF for intellectual disability is targeted by more than 30 states. 20 states are targeting managed care organizations. It turns out ambulance companies are a big target of these, and there's about 20 of those also. And then there are smaller numbers for other types of providers, but other types can be targeted. Now, here's the key thing. You have to kind of forget about the usual way you think of taxation here, because providers actually usually support the tax. They support being taxed. And it's very normal for the state to sort of design the tax with some kind of consultation with the providers. And the reason for that is states will often use some of the funding to improve provider rates. In some purposes, in some situations, the purpose of the provider tax may be to actually address some rate problem with some group of providers. So if you just imagine there's a state and there's a big budget hole and there's legislation out there proposing to cut provider taxes, provider rates, sorry. And then the state, it approaches the providers and it says, hey, you know what? We could do a tax and avoid the rate cuts, right? And it ends up being better for everyone. Now, there are a lot of rules about how this works, right? I'm in DC. We're about to hit peak cherry blossom season, right? This is like peak wonky for these slides. So just bear with this slide. there are a lot of rules around provider taxes, and this is sort of a rabbit hole. We're only going to dip our toe in to understand how the GOP is proposing to make the cuts here. When provider taxes really started happening back in the 80s, there were problems. Sometimes states were actually abusing the agreement to get excessive federal match. So that was a problem in the 1980s. In 1991, Congress passed a flurry of laws to deal with that. And so now that we have laws and regulations to prevent states from gaming the system, under the law, there are sort of three big requirements. The taxes have to be broad, meaning you have to tax all providers in the class. You can't cherry pick which ones you want to target. The tax has to be uniform, meaning you generally have to charge everybody you're taxing the same tax rate. And third, there can be no direct or indirect arrangement to hold a hospital harmless from the tax, meaning you can't guarantee the hospital like a refund, right? You can't say, hey, hospital, just pay the tax and later we'll pay you back whatever you put in. Now, that's where things get a little messy, because if the state uses the provider tax to raise money that it uses to do a Medicaid expansion or to raise some provider rates, what if the hospital recoups 10% of the tax payment or 50% of the tax payment or even the whole tax payment, right? They get it back through these increases. Is that a hold harmless violation? Well, the answer is no. The basic answer is that states can absolutely use the tax to raise rates that and improve coverage in ways that will benefit providers, including hospitals. But to keep it under control, there's one more rule, which is that if the tax is set at more than 6% of provider revenue, then the state must meet very onerous additional standards to basically prove that the rate increase isn't a backdoor refund for those providers. And so because of this, it turns out that no states go over 6%. And there are a whole bunch of states that come in between 5 and 6%, right? So basically, states aren't using this more than that cap because they don't want to get those onerous requirements. And what the Republican proposal does is it says we're going to lower that limit from 6% to 4% in 26 and 2027, and then 3% after that. And so what that effectively does is it reduces the outer limit on how much states can use provider taxes and will dramatically reduce the amount of money states can raise through provider taxes. And don't get too obsessed with this 6% mechanism, because there are a lot of other ways you could mess with the provider tax mechanism to pull money out of it. You could say, for example, hey, you can only do one provider tax per state, or there are other ways they could cut it. This is the way they chose to cut it. The point of this is that if you reduce it per their proposal, it cuts $175 billion out of the system. But the GAO has scored that if you totally reduced it, right, if you took the 6% and just moved it to zero, nobody can do this at all, you would cut $630 billion in spending. So you can just see that if the Republicans are short on money to fund their other things like tax cuts, they could try and really ratchet up the damage they do through this provider tax. $175 billion is already brutal, but they could do it a lot more. So what would be the effects of that? What are the impacts of that? So first, the states without the provider tax can't raise as much money, right? Remember, we said 17% of the money is raised that way. But second, the reason that this reduces federal spending is that the feds don't have to match any dollars that the states can't raise and spend. So you cut the state dollars and you cut the federal match, right? And you're basically eliminating that lifeboat, right? So that's our first point. Second, states that financed Medicaid expansion or other projects using this provider tax will lose their Medicaid expansions and other projects. And in the 10 states that haven't expanded Medicaid yet, it's a lot harder to see them getting to yes if they don't have this financing mechanism available. And third, providers will be hit very hard because states rely on this revenue to help supplement the low Medicaid payment rates. I probably don't need to tell people in this audience about how low Medicaid payment rates are, but you know that the base payment rates are paying half of the costs, less than half of the costs here, right? So the supplemental payments that are made using provider taxes to raise the money are essential to our healthcare safety net. So let's talk about our second topic, which is cut to Medicaid expansion and how that interacts with people with disabilities. So it's really important that we all understand this point that we're going to go through here and make sure that everyone in your networks understands this, because Medicaid expansion is just flatly misunderstood by critics. Sometimes it may be people who are intentionally burying their head in the sand, but I think there's also just a lot of genuine misunderstanding. You may hear this talking point that Medicaid expansion is only for able-bodied individuals, right? Not terminology I like, but the more important point is, yeah, that is false. You will also hear states say sometimes, or critics say, states investing in Medicaid expansion actually hurts people with disabilities and other traditional populations because they're taking money away from people with disabilities. That is exactly backwards. The truth is that Medicaid expansion is critical for people with disabilities, also critical for pregnant people, by the way, also for kids and other traditional populations. Um, Medicaid expansion includes individuals with a very wide range of disability status or functional status or chronic illness. And let me make 2 points that we'll flesh out on the next slides. First, the general income limits for disability are very low. And in fact, they are lower than the Medicaid expansion eligibility limits. So people with disabilities are sometimes not eligible for the disability category, and they are eligible for Medicaid expansion. Second, the Social Security disability standards are so strict that many people with disabilities who do have low income don't meet those standards, don't qualify for SSI, so they're not getting into Medicaid through the disability pathway. So you have all these people with disabilities who, because of their income or because of their disability or some other reason, are not qualifying through that standard disability channel. And it's only because of Medicaid expansion that they have health insurance. And so let's talk about the income piece first. States must generally enroll SSI enrollees into Medicaid, but that income limit minimum is only about 75% of federal poverty. And there are 23 states that only do that minimum. You have 17 states in DC who go up to 100%. There are 9 states that sort of lie somewhere between 75 and 100%. The median state is only at 80%. There's only one state, California, that takes disability all the way up to the Medicaid expansion level, right? So we give California a gold star. But what we're saying is in about half the states, if you are between 75% and 138% of federal poverty, 75 to 138, regardless of what a Social Security disability you have, you are not going to get in through the normal disability pathway. You're likely to be not enrolled unless there's a Medicaid expansion for you. There may be some other paths to enrollment for disability that may have higher income limits, like your state may have a waiver that has a higher income limit if you meet a functional test, right? But the state might not have that, and not everyone qualifies for that particular one, right? So bottom line is, it's not that you have to be able-bodied to be in Medicaid expansion, right? It's that you have to meet the income limit. And that's true regardless of your abilities, capacities, challenges, et cetera. And that should be hopefully obvious from this data. Now, our second point is about disability. And I'm not a disability expert, but I know enough to know this. People are different. They have differing abilities, challenges, skills. There's a lot of variation in the world. So when I use the term disability, I use it broadly and inclusively. But it turns out the Social Security disability standards are extremely strict, and I actually prefer to say they're extremely particular, right? Some people with certain types of disabilities get a yes, other people with other types of disabilities get to no. If we look at census data, if you look at the people who are enrolled in Medicaid, 63% of them are not qualifying for Medicaid through the SSI-related pathway, right? So if you imagine Medicaid is a house, and you imagine there is an official room built for people with disabilities in the house, it turns out that only 37% of the people in the house are actually in that official disability room. Most of the people in the house, most of the people in Medicaid are in other rooms. And one of the big rooms where a lot of them are is Medicaid expansion for the reasons we just talked about. There was a great KFF cut of the data in 2019 that showed this even clearer, that it's 68% in the expansion states and it's 53% in the non-expansion states. So in other words, when you have a state that expands Medicaid, you have a whole lot of people with disabilities coming into the program, not in the disability category. Why? Because they're coming into Medicaid expansion. What does this mean for impact? Well, we can see all of this in the evidence on impact, right? This isn't just hypothetical. We have out there tons of evidence about how expansion has been helpful to parents, to adults, to the health workers that take care of everyone. We have evidence about how great it's been for kids because, surprise, surprise, you need me, a research professor, to tell you that kids are better off if their parents don't die of a preventable illness, right? You don't need me to tell you that. So this has been great across the populations, and it's been great for states, and it's been great for state budgets and state economies and state labor markets. But based on what I've told you, it should also be no surprise that Medicaid expansion has been great for people with disabilities. They are more likely to have a full year of coverage, more likely to receive primary and preventive care, and to have reduced out-of-pocket expenses. And studies have shown these coverage gains are very broad in a lot of different areas. People with disabilities in general, but also substance use disorder, including opioid disorder, people with HIV, people who are screened positive for depression, adults with diabetes, cancer patients, cancer survivors, adults with a history of cardiovascular disease. You just kind of run across the spectrum. All of these groups do better in a state that has expanded Medicaid. And in Medicaid expansion states, it also won't surprise you that there are increases in the number of people with disabilities who are working and decreases in the number of people with disabilities who report not working due to a disability. And you don't see that same effect in the non-expansion states. And a last inspiring point on this topic is that you also see with Medicaid expansion less take up of SSI, right? And the important point about that is if you're a low-wage worker with a disability and you can do some work, and the data shows there's a lot of people out there who are like this, they don't get stuck in this situation of, well, I have to go apply for SSI so that I can one day get healthcare, right? With Medicaid expansion, they can be sure of having healthcare. If they want to go out and work, they can. If they want to apply for Social Security, of course they can if it makes sense for them, but they're not forced to. So our bottom line here is that Medicaid expansion has been incredible for all populations and states, but also really critical for people with disabilities. So you may hear this misinformation about able-bodied, but as we can see, it's just factually and actually wrong. And if you look at these GOP proposals, all of the ones being considered that are cutting Medicaid expansion, these are issues for all populations, including people with disabilities. These are disability issues. This is the way working families get their coverage. It's also the way people with disabilities get their coverage. So per capita caps, which could be implemented broadly, but could also be targeted at Medicaid expansion. Don't let anyone tell you that that doesn't hurt working families or people with disabilities. Reducing the Medicaid expansion match would also be a giant cut for people with disabilities. Work requirements are particularly harmful for people with disabilities. The population is so, you may hear people say, oh, don't worry, people with disabilities are exempted. Well, remember two things. I already said the population is really diverse, so it's impossible to design criteria that will create exceptions for all of the different types of disabilities that are out there. So tons of people with disabilities lose with whatever criteria they draw. But second, even when you take these terrible criteria and you try and use them, there is no unicorn out there that magically identifies who meets these criteria, right? If you're in substance use disorder treatment or you have a mental health condition or a chronic health problem, how are you going to prove it? There's no magic database out there. So people are going to have the burden of figuring out there's a work requirement, figuring out the exception criteria, figuring out how you meet the criteria, going to the doctor or clinic or getting whatever proof they need to do this, and then submit that to the state and follow up with the state, right? And they have to do that while they have a substance abuse problem, while they have clinical depression, right? So just a lot of people aren't going to make it. It just doesn't work in reality. So I'm going to close with two slides addressing a fact and a fiction. And we're actually going to start with the fiction. And Gail really hit this already. The first fiction is that these cuts are just targeting waste, right? Let's look at this. And I just want to make two basic points. They have exactly three major policy proposals to cut Medicaid that are in excess of $200 billion each. The first is the per capita cap, which is an across-the-board cut to Medicaid rates, in no way, shape, or form targeted at fraud or waste, just a flat cut. Then we have reducing the Medicaid expansion match, which again, no way, shape, or form is targeted at waste or fraud. And then they have reducing the minimum match, targeting 12 states for just a flat across the board cut, in no way, shape, or form targeting waste and abuse. That is where their cuts are. And those are their three highways to their 880 number. That's $2 trillion in cuts I just described. They have nothing to do with waste, fraud, and abuse. So they can talk about waste, fraud, and abuse, but that is not the proposal that is on the table. And so I would just encourage everybody to remember, like, if it walks like a duck, it quacks like a duck, it's probably a duck. They need big cuts to fund their legislation. They have proposals that make big cuts, but it's not about waste and fraud. And the second point that I think is really important is, I think all my colleagues believe that there are efficiencies to be found in Medicaid. It's a big program. A lot of people covered, spends a lot of money. Of course, there are efficiencies to be found, and we all want to find those efficiencies. But burning down the forest is not how you deal with a bad tree. These cuts hurt all the states that are not being wasteful. And if there is a state out there being wasteful, it doesn't stop their waste, right? It just reduces the size of their waste, right? That's not what we want. And I'm going to close with this last kind of scary fact. Sorry. People with disabilities and their providers should be on the highest level alert about these cuts. Why? Well, eligibility and services for populations like kids and parents are more often than not mandatory, meaning the state cannot cut them, and they are more often than not inexpensive, right? Kids are not expensive to take care of. In contrast, eligibility and services for people with disabilities and older adults are much more likely to be optional eligibility, much more likely to be optional services, and much more likely to be expensive, right? And so if you need to close, if you're a state and you get hit with these big federal reductions in funding and you need to close a budget hole, where are you going to make cuts? You're going to make cuts where the money is. You're going to go to where the money is, right? And that's optional categories for people with disabilities and older adults, right? Like waiver programs. Optional services in Medicaid, like therapies, personal care, private duty nursing. And you could also set caps on access to the services, right? And then you're going to go after provider rates. There's only so much money you can get from cutting wellness visits for kids, right? So where are they going to get the money from provider rates? Again, they're going to get it from the services that complex populations depend on. So bottom line, if the feds make these cuts, people with disabilities and older adults are going to bear the brunt of the downstream impact in states when states turn around to make cuts, right? There's no way these ideas don't lead to really bad places for complex populations and their providers.
Thank you, Leo. That was so thorough. And I think we do have a couple of questions in the chat. If you're willing to just entertain a couple quickly. First, there was a question about, do you have any visuals that sort of demonstrate what you're speaking to? You have one in your slides, but I think the question is, as you were talking through, especially your second to last slide when you were talking about where the optional are and so forth. Do you have anything that illustrates that?
Sure. So we have, you can sort of see slides or charts that will show you what are the mandatory services in Medicaid, what are the optional services in Medicaid. And there are also KFF resources, and I can help find these and share these. There are also KFF resources that I think do a good job of talking about how much of the spending is optional spending, which will sort of point you to where the cuts are likely to happen if somebody was going to do cuts.
And then there was a question about citizenship related to Medicaid. I just wondered if you had any light to shed on that. I think we're already starting to see that, but would love any comments you might.
Sorry, you cut out when you asked, was that citizenship related to Medicaid?
Yes.
Yeah, so right now, the way the Medicaid program works, there are some groups of qualified immigrants. So these are, generally speaking, immigrants who have, of course, a lawful status and have been um, approved to be in the United States on a long-term basis, like somebody granted asylum who can access Medicaid. There is a large group of immigrants, both the undocumented, also many legal immigrants who cannot access full Medicaid enrollment. The only enrollment that those immigrants can access is emergency Medicaid, which basically will reimburse um, emergency room visits, emergency treatment for those individuals. Um, and 50% of that money is labor and delivery. So if you imagine an undocumented immigrant who shows up at a hospital in labor and the delivery happens, the hospital can then bill Medicaid for those services for that person, limited to that emergency provision. So that's the way it is right now. There have been some vague proposals that have been floated by the Trump administration that honestly, we don't quite understand what the proposal is because, for example, they say things like, we are going to stop undocumented immigrants getting benefits that they're not authorized to get. But there is no such thing happening in Medicaid. So I don't know exactly what that means. It would be really devastating for hospitals and the healthcare infrastructure if the 50% of spending that goes to labor and delivery stopped happening. That would be, if you just think about a country where we already have a problem with not enough OB units and not enough capacity to deliver babies, if you stopped paying hospitals to deliver those babies for a segment of the population, that would just be catastrophic. So it would be a really bad policy move to change that policy.
Thank you, Leo. Really super helpful. And I know I think we can make your slides available. And also would love to have you back as this continues to evolve. So thank you to both you and Gail. I want to just ask, I had a couple remaining slides because then the question is what's next, right? What can you be doing? What should you be doing? So reminder about the key decision makers, right? Of course, Gail from Energy and Commerce Committee with us today. But as this continues to move forward, these are the committees that have jurisdiction. We have a target list. We've been doing a lot of outreach to many of you individually. We are trying to coordinate group visits to target lawmakers. So these are the committees that'll continue to be really relevant as we move through this process. Next slide. And then, right, what can you do? So if you haven't already, we continue to share advocacy updates, including our alerts. So if you haven't already, please use that. Take the time to either call or write your member of Congress to voice your opposition to cuts to Medicaid. And I did update the slide, but the Congress is in recess from April 13th to the 27th, which means they're back home. And that is the time to ask for a meeting, take your other colleagues and partners with you and the people that you work with that are part of Medicaid. Attend town hall visits, request them to come to you and do a site visit. That is the peak time from April 13th to the 27th when both Senate and House members will be home. And that's a great time to engage them. And then, of course, this forum, our Capitol Conversations, will be ongoing. Our next one is scheduled for April 17th. So we'll continue to share updates to Medicaid and also other key issues that we're following. So with that, I want to thank.
Sorry, we
want
to send
please.
one last poll really quick and then go ahead.
Thank you, Bill. And thanks to Bill for organizing this. We did invite House Energy and Commerce staff from the majority to be with us as well, and they were not able to make it. So today, the post, right after the conclusion, do you feel more likely to advocate? And it looks like a number of you are saying Yes. Which is great. And please reach out to myself or Bill with any questions. We are here. We are actively working to continue to keep you all updated. So thank you again to Leo and to Gail and to Bill for organizing this, and great to see you all. Thank you so much.
Thank you all.